Welcome to The Explainer. Okay, today we are tackling a universal clinical challenge. Honestly, whether you're a family physician, a physical therapist, a nurse practitioner, or an orthopedic specialist, you see this on a nearly daily basis. We're talking about the clinical conundrum of evaluating and treating lower back pain. It's easily one of the most common, yet somehow most nuanced, presentations in all of clinical medicine. All right, let's dive right into this. Just think about this number for a second. 84%. Up to 84% of adults worldwide are going to experience low back pain at some point in their lives. And the global point prevalence for activity-limiting back pain? That's a staggering 12% at any given moment. This firmly establishes lower back pain as a massive global burden. It's a leading cause of disability worldwide, and let's be real, it's one of the absolute primary reasons a patient is going to be sitting on your exam table tomorrow morning. But here's where it gets tricky, right? The real clinical challenge. While the raw volume of patients is just staggering, over 85% of these cases are nonspecific mechanical back pain. Then, about 14% have specific subacute or chronic conditions, things like spinal stenosis or radiculopathy. And then there's that tiny fraction, literally less than 1%, that represents urgent acute conditions like Cauda equina syndrome, spinal epidural abscess, or malignancy. So we're essentially looking at a massive clinical haystack. Our primary job is to find those extremely rare, dangerous needles without over-medicalizing or over-treating absolutely everyone else. Here is our clinical roadmap for today's explainer. 1. The global back pain burden. 2. Hunting for red flags. 3. The focused neurological exam. 4. The advanced imaging trap. 5. Evidence-based management strategies. And finally, 6. Navigating chronic occupational pain. Let's get to it.
Section 1. The global back pain burden. Let's really understand this haystack.
Picture this. Your next patient walks in. It's a 45-year-old accountant complaining of an aching lower back after a weekend of yard work. As we've established, the overwhelming majority of cases present a really unique diagnostic challenge, mostly because there's no single confirmatory test. We are constantly weighing a stark contrast. On one hand, we have non-specific mechanical back pain, muscle strains, degenerative disc disease, facet arthropathy, which we basically have to diagnose presumptively. But on the other hand, we have urgent red flag pathology. We're talking spinal cord compression, Cauda equina syndrome, metastases, and spinal epidural abscess. Missing one of those rare cases can lead to absolutely devastating, irreversible outcomes for the patient. So how do we reliably tell them apart in the middle of a busy clinic day?
Section 2. Hunting for red flags through structured history taking.
When we take a history, we aren't just routinely gathering data, we are actively hunting for clues. A great way to do this is by using the ABCDE heuristic to filter out that less than 1% of patients who need immediate, life-saving intervention. A stands for aortic aneurysm. Always keep retroperitoneal bleeding in the back of your mind. B is for bone fracture or bleeding, so look for focal bony tenderness or a history of trauma. C is for cancer. If they have a personal history of cancer or unexplained weight loss, that is a huge red flag. D is for disc-related emergencies, like Cauda equina syndrome, which is characterized by saddle anesthesia, diminished rectal tone, or severe bilateral weakness. And E is for epidural abscess or infection, especially if the patient has a fever, is immunocompromised, or has a history of IV drug use. If your patient mentions any of these features, your clinical alarm bells should be ringing incredibly loudly.
Section 3. The focused neurological exam. Localizing the lesion.
Now, once we've taken a targeted history, our primary goal in the physical exam is localizing the lesion. We want to identify if there's a radiculopathy and map it directly to our anatomical knowledge of the spine. What's really cool is how cleanly solitary nerve root lesions map out to specific motor weaknesses and incredibly simple screening maneuvers you can do right there in the clinic. Keep in mind, over 90% of lumbosacral radiculopathies involve the L5 and S1 nerve roots. For an L4 issue, you're going to see weakness in the extension of the quadriceps. Just have the patient do a squat and rise to screen for it. For L5, watch for weakness in the dorsiflexion of the great toe and screen them by asking them to walk on their heels. And for S1, you're looking at plantar flexion weakness, which you can easily screen by having the patient walk on their toes. These are super fast, highly targeted tests that give you massive diagnostic clarity before you even think about ordering an expensive scan. Sometimes the pattern of the pain literally tells the whole story. This is especially true if your patient is an older adult complaining of leg pain when they walk to the grocery store. Let's quickly contrast neurogenic claudication with vascular claudication. Neurogenic claudication, which is often caused by lumbar spinal stenosis or degenerative spondylolisthesis, presents as ambulation-induced pain, localized down in the calf and distal lower extremity. But the true hallmark here? It resolves when the patient sits or leans forward. It's the classic shopping cart sign because leaning forward biomechanically opens up that spinal canal. Vascular claudication, on the other hand, is brought on by a very specific, predictable degree of exercise and is typically relieved simply by standing still and resting. It's a subtle distinction, sure, but it dictates entirely different diagnostic pathways. Section 4. The advanced imaging trap. When do we actually need to scan? This brings us to what might be the climax of our clinical narrative today. Over-imaging acute back pain is widely considered a massive pitfall in modern medicine. So I want to pose this direct question to you. Think back to that 45-year-old accountant from earlier. Does this patient, your standard acute back pain presentation with absolutely zero red flags, need an MRI today? We really need to aggressively challenge the misconception that every twinge, muscle strain, or acute backache requires an immediate trip to the MRI scanner just to find out what's wrong. The evidence-based answer? A resounding no. Here is the strict guideline-based imaging algorithm we really should be following. Step 1. Address progressive neurological deficits. If you suspect Cauda equina syndrome or spinal cord compression, yes, absolutely, get an immediate, emergent MRI. Step 2. Assess infection or cancer risk. If there's moderate clinical suspicion, use inflammatory markers like ESR or CRP to guide you before jumping straight to a scan. Step 3. Use plain films if you suspect a fracture risk due to trauma or osteoporosis. But for routine, acute paces under 6 weeks, avoid imaging entirely. The surprising reality is that approximately 95% of patients in primary care will not require immediate imaging. So the absolutely crucial point here is summarized perfectly in this quote from the clinical guidelines. The presence of degenerative changes on spinal imaging does not exclude the diagnosis of non-specific back pain because such findings do not reliably correlate with symptoms. Treating the scan rather than the actual patient is a huge trap. Finding an incidental bulging disc or mild stenosis in a patient with nonspecific pain can cause immense, unnecessary anxiety. It leads to overtreatment, and it can actually worsen patient outcomes because suddenly they're terrified to simply bend over and tie their shoes.
Section 5. Evidence-based management strategies. Our first-line care.
Okay, once we've ruled out serious pathology and successfully dodged the imaging trap, what do we actually do for the patient sitting in front of us who is hurting and just wants relief? The core conservative treatments are straightforward, but they require excellent empathetic communication. First up, patient education is paramount. You've got to reassure them, strongly advise them to avoid strict bed rest, and encourage them to stay as active as they safely can. For pharmacotherapy, nonsteroidal anti-inflammatory drugs, NSAIDs, are your first-line defense. And let's explicitly call out the don'ts here. Avoid opioids and sedating drugs. The evidence is clear. They lack clear benefit for nonspecific pain and are heavily associated with longer work disability and potential for harm. Finally, consider an early referral for physical therapy, especially if their recovery is delayed or if they're struggling to meet the physical demands of their job. Let's move on and see how this builds across the expected timeline of a back pain episode. In the acute phase, which is anything under 4 weeks, rapid improvement is definitely the norm with conservative care. But in the subacute phase, from 4 to 12 weeks, the likelihood of a self-limited recovery really starts to decline. We need to monitor these patients closely. By the time they hit the chronic phase, 12 weeks and beyond, full resolution becomes much harder to achieve. This is where we occasionally have to escalate care to interventional treatments like epidural glucocorticoid injections for confirmed radiculopathy, or even considering surgical referrals if there are severe progressive motor deficits that just aren't improving.
Section 6. Navigating chronic occupational pain, the biopsychosocial model.
But what happens when the pain persists, especially in the workplace? Chronic pain is rarely just a mechanical issue in the spine. Work-related back pain is incredibly complex, and it's associated with significantly increased rates of recovery delay and chronic work disability compared to non-occupational back pain. We absolutely have to consider psychosocial predictors of prolonged disability. Things like fear avoidance behavior, where patients are literally terrified that moving will cause further damage, or catastrophizing, where they imagine the worst possible permanent outcome. You also have to look at perceived injustice, a lack of supervisor support, low job satisfaction, and Waddell's non-organic signs on the physical exam. These psychosocial and occupational factors heavily influence disability and can completely derail a patient's physical recovery regardless of what their MRI says. To effectively combat this, we have to use risk stratification. We can leverage validated tools like the StartBack tool and the Orebro musculoskeletal pain screening questionnaire. These are really simple surveys that help us identify high-risk patients early on in their clinical journey. Instead of just handing a high-risk patient more NSAIDs or ordering yet another scan, we can refer them for targeted multidisciplinary interventions. Think cognitive behavioral therapy combined with specialized, work-focused physical therapy to actively reframe their beliefs about pain and movement. It's a real game changer.
We also have to zoom out and consider the patient's age and overall health context. There's this striking quote from the literature regarding older populations. In older adults, chronic low back pain can be considered a geriatric syndrome, a final common pathway for the expression of multiple potential contributors. It's like a giant puzzle. We have to look way beyond just the lumbar spine and evaluate co-contributing factors, things like hip osteoarthritis, undiagnosed depression, and severe insomnia. All of those amplify the experience of pain and severely hinder rehabilitation.
Which leads me to a final provocative question for you to ponder. At your next back pain consultation, are you treating just the spine, or are you treating the entire biopsychosocial patient? By truly understanding the global epidemiology, rigorously hunting for those rare red flags, avoiding the advanced imaging trap, and addressing the whole person, we can fundamentally transform how we manage this universal clinical challenge. Thank you so much for joining this explainer, and we will catch you next time.